Hello, sir. Good morning. So, sir, my name is Dr. Sahan of the PACES candidate here today. I've been asked to examine your tummy. So, sir, what I'm going to do, I'd like to have a very good look first and then feel, then tapping and listen to your tummy. So, do you have any pain right at this moment at your tummy? No. All right. So, during this procedure, if you feel any kinds of pain or discomfort, just let me know. I'll stop at that moment. So yes, my dear doctor, immediately after entering the room, that the station 1 abdomen, that you need to do all the G bundle together, my dear. So the G for good greetings, introduction, instructions, and pain, position, and pose are right there. You already finished the good greetings, instruction, introduction, and pain that you already have done. Then the position is lying flat is absolutely fine, and the pose arm is the exposure, that you need to expose the mid chest to mid thigh. Yes, my dear doctor. So you need to tell him, sir, just could you please sit forward for me? Yes. Just put off your gown and put off your shirt and you can help him. Yes, give it to me. So yes, sir, can you just lie back for me? Yes, thank you. So you are now ready to examine him for the abdomen examination. And of course, the abdomen examination starts from the hands. But my dear, listen very carefully. You enter into the room for the station 1, and you have seen at an inspection, there's a plethoric phase. So having a plethoric phase that I observed. So the plethoric phase, the first diagnosis, my dear, polycythemia. And definitely the cases will be in your exam, my dear. Polycythemia rubra vera means the primary polycythemia. So it's a spot diagnosis that you can make your diagnosis, the polycythemia rubra vera. Now we need to do work to get the findings in our hands all together. So let's see and start the examination from the hands first. So start the examination from the hands first. So, sir, can you do like this for me, just hands? So, yes, we can see that he doesn't have the clubbing, no leukonychia. But what we have seen that he has got the extreme plethora, the red complexion. Yes. So immediately after that, when that hand turned around, so you need to tell him that could you please turn your hands for me, and then you can compare with my own hands with his hands. The palms are really plethoric and red complexion. So now you need to tell him just spread your fingers or stretch your fingers. Now cock up your wrist back. Yes, you need to hold it here and you need to press here to see the flaps. So that he has no flaps, no flapping tremor. There's no evidence of hepatic encephalopathy. Immediately after the hands examination that we are going up, and we can see and observe that the skins are really plethoric skin and multiple bruises and ecchymosis altogether. But in the antecubital fossa that we can see that you see the 3 marks here, there is a venesection marks. And venesection marks is really important, that you can see the venesection marks here. You can see the venesection marks. We can see the venesection marks, you see the venesection marks. So now we can look at her face, that we can see the face is really typically plethoric and very red complexion. It's a diagnostic for the polycythemia rubra vera. Is a primary polycythemia, is the most likely diagnosis that is usually encountered in your exam, my dear. So you can see the plethora, and these are phase of the full face is plethoric. And now we can look up. Can you just tell him, just look down for me? Stop. So no jaundice, and look up for me. So you see the conjunctival vessels are really congested. So he has got the, yes, these are also important findings of polycythemia rubra vera. So yes, we can see that you can compare with my own hands, that you see my hands color and his face color. So that we can compare the complexion right there. And can you look up for me? And you can see the conjunctival vessels, and the vessels are really congested. And you can see the congested vessels. So we can see the congested vessels here are really congested. And here is also, you can see the congested vessels. So stick your tongue out for me, then tongue up. Yes. Now, okay, fine. Now show me your gum. So there is no gum hyperplasia. So immediately after the phase examination, that you're getting down to the upper chest to look for the spider nevi. He doesn't have any spider nevi. And also the loss of body hair. So he has the body hair and gynecomastia. He doesn't have the gynecomastia. So these are not there, not the features of the chronic liver disease. But what we have seen that we have seen the skin is really plethoric, and also we have seen some of the scratch marks here, scratch marks here, scratch marks here. So if you can come closer, close view, close view, close view, close view. Yes, you can see the scratch marks here, scratch marks, multiple scratch marks are there. And also we can see some of the scratch marks of the body here. Now getting down to the abdomen, the abdominal wall, that inspection, that what we have seen, that yes, we have seen a midline laparotomy scar, but this is half the way the total midline, a small midline laparotomy scar. And this small midline laparotomy scar, in the context of the polycythemia rubra that you should think about, this is nothing but the splenectomy scar. Splenectomy scar can be, means the splenectomy approach can be done by the laparotomy, that the midline laparotomy, or upper half of the laparotomy, and also maybe the left subcostal scar mark sometimes. Or maybe sometimes the laparoscopic scar, maybe there. But here that we have seen the upper mid half, the mid laparotomy scar is a splenectomy scar. But along with that, that we have seen some of the multiple scratch marks that we have seen, that if we can get closer, that we can see the scratch marks of the, yes, and the scratch marks. You see the scratch marks here. This is the scratch marks. Yes. And also multiple scratch marks also here. You see the multiple scratch marks are here. So these are the scratch marks that you can see. And these scratch marks is nothing but the pruritus, one of the important features for the polycythemia rubra. But here's the scar mark that we can get closer to look for the scar mark, the midline upper half laparotomy scar is nothing but the splenectomy scar. So here's, my dear, immediately after the inspection, that you can palpate for the superficial palpation or any tenderness, any painful, then you can ask him that, sir, if you have any other pain, just let me know. Immediately after the deep palpation starts from the liver, that you can put it here, the hands here, and you need to tell him, turn your head on the left side for me. Yes. And take a deep breath in and out for me. Once again. Sir, once again. Once again. Once again. Once again. Once again. So, I have not found the liver is enlarged and not palpable as well. I need to tympanic, all through the tympanic. And now we need to see the upper border of the liver dullness. Now see the upper border of liver dullness from here. So there's a down, so second, third, fourth, and fifth intervals of space. So there's normal, liver is not palpable, not enlarged. So immediately after the liver, this palpation, that you need to palpate for the spleen here. It's because you have understood the spleen is not there, but even then you need to do that. Take a deep breath in and out. Once again. Once again. So once again. Once again. I need to turn him on the right hand side. And to hold it here. Once again. Take a deep breath in and out. Once again. Once again. So the spleen is not there definitely. So there's the dal. This is tympanic. This is tympanic. So you can now turn back. Immediately after the liver and spleen palpation, then you need to put your hands for the kidneys, my dear, for the palpable and palatable, and for the palpable and palatable. So the kidneys are not palpable, not palatable, not enlarged. Immediately after that, the urinary bladder, then you need to palpate and just do acting, my dear. Yes, the bladder is not also palpable, and this is the end of the palpation. And then you need to take the percuss and tapping on the abdomen for the percussion, my dear. I need to put the hands here for the percussion. The tympanic, 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 tympanic. So as because this is the tympanic, so you don't need to the shifting dullness test. So immediately after that, the percussion that you finish, my dear, you need to put the stethoscope for here, for the auscultation of the bowel sounds. And bowel sounds are present. And then you need to turn around to put it here for the renal bruise are absent, and then put it here over the epigastrium for the venous hum, which is the feature of the portal hypertension. So yes, this is also absent. So that's the end of the auscultation here. So immediately after that, you finish your examination of the abdomen proper. Then you need to come back to the legs, my dear, and you need to put your hands here. You need to tell him, sir, do you have any pain in your legs? So he's saying that he has got the pain and tenderness on the right leg. So I'm not giving the pain here because I've seen a stocking here. So this is the stocking here. So yes. So the right leg has got the stocking. So you can see the stocking here. And this stocking essentially means that he has got the right-sided DVT, means the deep vein thrombosis. That's because he said that his right leg is more swollen than the left leg. So definitely he has got the right-sided DVT, right leg DVT. So this DVT, so that's why I'm not going for examining the right leg now, but on the left leg that we can see that he has got the multiple bruises as well as the ecchymosis. So on the left leg that we can see, that he has the multiple bruises as well as the big ecchymosis. So he has got the left leg, you see the left leg having some of the multiple bruises, but a big ecchymosis that we can see the reddish color surrounded by the blackish, bluish black color. You see that if you get closer, so you can see the bluish color. So yes, my dear doctor, immediately after that you finished your examination, that you felt that you need to examine the legs for the leg edema, definitely. Immediately after the leg edema, L for lymph node examination, you need to tell him, sir, could you please sit forward for me? I need to see the anterior chain, then the posterior chain, then the supraclavicular lymph nodes. So the lymph nodes are not enlarged, not palpable. And in the meantime that we can see onto the back, that I can see the back is also some of the plethoric complexions and also the nose sacral edema as well, and nose scar marks on the back as well. And whenever you feel that you finished your examination, then you give the clothes back, so you can cover him up, and you tell him, sir, you have done really excellent for me, and thank you very much. Thank you, sir. Just wear the shot and you can help him. So helping him means a lot in real exams. So you can make him lie him back, yes, and telling him, sir, thank you very much. Handshake. Thank you, sir. Thank you very much. Yes. And then you can wash your hands immediately after that. And you felt that you finished your examination, you can take the stethoscope in your hands, and also you come forward to the examiners, and then you need to tell them, sir, I'd like to finish my abdominal examination to check the hernial orifices, genital examination, and digital rectal examination. And I'd like to check the observation chart to see the pulse, temperature, respiratory rate, blood pressure, and oxygen saturation. And also I'd like to see the urine dipstick for sugar, protein, RBC, nitrites. So saying them all these three bundle packs all together means that you finish your examination, you'll get the full satisfactory marks, the full marks in examination part. Immediately after that, the examiner will ask you so many questions, or maybe you need to present your case. So presentation should be in a confident look, confident posture, and look into the both eyes of the both examiners and present your case. So the presentation, if you are confident enough, then you can present the first diagnosis first in your hands and then saying the other negative important points. So the presentation should be the way that I am saying. Sir, my clinical diagnosis of this gentleman is polycythemia rubra vera, or primary polycythemia, as evidenced by pruritus marks, means the scratch marks, multiple scratch marks, and the red complexion means the plethoric complexion that I found. And also I have seen that he has got the evidence of the hyperviscosity, as evidenced by he has got the right leg deep vein thrombosis, as evidenced by the right leg swollen and having the painful swelling of the right leg, along with the stockings that is in situ. And also I have seen that he has a big ecchymosis along with the multiple scratch marks and plethoric complexions altogether. So this means that he has got the polycythemia rubra vera. Along with that, I have seen he has got a midline laparotomy, half laparotomy scar mark. That does mean that he underwent the splenectomy. It may be the splenectomy might be done maybe due to some of the trauma of the spleen or something like that. So yes, but I have not found any other organ abnormalities, any other stigma of chronic liver disease, as evidenced by absence of clubbing, absence of leukonychia, spiral nevi, dupuytren's contracture, pulmonary edema, no flapping tremor. So yes, I have not found any other evidence of the chronic liver disease, and also I have not found any decompensation features like absence of jaundice, ascites, and encephalopathy. And also I have not found any features of portal hypertension, but he has got the splenectomy, so the spleen is not there, and also the liver is not also enlarged altogether. So putting all them together, my clinical diagnosis is the polycythemia rubra vera, as evidenced by the extreme pruritus marks and scratch marks and the red complexion, the plethoric complexion, as I said, and the viscosity means the hyperviscosity that is evidenced by the right leg deep vein thrombosis and ecchymosis over the left leg, and also the conjunctival congestion. The vessels are really engorged and visible very well, so that this is the features of hyperviscosity. And also I have seen that he underwent the splenectomy. So the examiners may ask you so many questions. And the polycythemia rubra vera is a primary polycythemia. So I like to do the confirm my diagnosis, because the primary polycythemia is nothing but the myeloproliferative disorders. And myeloproliferative disorder, RPC, is a polycythemia rubra vera, WBC for the chronic myeloid leukemia, platelets for the essential thrombocythemia, and the myelofibrosis. The four important diseases altogether, we call it myeloproliferative disorders. Among them, yes, all the myeloproliferative disorders will have the splenomegaly. Yes, because we have found the splenomegaly and also the plethora. In his case, that we found the splenectomized polycythemia rubra vera. But yes, the cases with the plethora with the splenomegaly, the diagnosis that you should think about, polycythemia rubra vera. The approach is to reach the diagnosis, the test that you need to do to exclude the other secondary causes. So what you need to do, we need to confirm the diagnosis, the primary polycythemia rubra vera, to confirm first the red cell mass. And red cell mass definitely should be increased, and that of the normal, and that is the diagnosis of the polycythemia. And the JAK2 mutation test should be done if this is positive, more than 90-95% cases in polycythemia rubra vera. So the diagnosis for the polycythemia rubra vera. Along with that, we need to exclude the secondary causes by doing the erythropoietin level. Erythropoietin level will be normal, increased in the secondary causes. And also that we need to do the WBC, platelets, and also the splenomegaly, yes, along with the vitamin B12 binding protein. These are the bundle packs are really present in case of primary, absent in case of secondary. It does mean that the platelets and WBC will be increased because of myeloproliferative, so that all the cells will be increased. In contrast, the secondary, definitely the platelets and WBC will be absent, means not increased. And the splenomegaly is present in primary, splenomegaly is absent in secondary, and vitamin B12 binding protein will be increased in case of primary and definitely not increased in case of secondary. Along with that, one of the most important points might be LAP score, means the leukocyte alkaline phosphatase score, or NAP score, that is a neutrophil alkaline phosphatase score, that will be definitely increased in case of primary, but secondary it will not be increased. But in case of secondary, there will be the erythropoietin level will be increased, but not increased in case of primary. So the raised erythropoietin level is a clue to reach the diagnosis and to differentiate from primary to secondary. And whenever the raised erythropoietin level, so we need to think about some of the physiological causes and some pathological causes. Physiological causes include the hypoxia. Hypoxia is a trigger to release the erythropoietin level. So hypoxia caused by, number one, the chronic lung disease. Chronic lung disease, it includes the chronic bronchial asthma, chronic obstructive pulmonary disease, then the bronchiectasis and pulmonary fibrosis. These are the four diseases we call the chronic lung disease. So the chronic lung disease leads to the hypoxia. Second is a cyanotic congenital heart disease. Yes, TOF, TGA, and these are the disease that causes, yes, hypoxia. So this is the physiological causes under the headings of the heart and lungs. And next to the pathological disease, the most important disease, number one, that we need to remember, there is a ADPKD, the autosomal dominant polycystic kidney disease, the kidney disease, along with the RCC, renal cell carcinoma, and the liver is a hepatocellular carcinoma. So RCC, HCC, and RCC renal means the ADPKD. So my dear, what you need to do, we need to evaluate that to exclude that, at least the heart, lungs, and liver and kidneys to be excluded beforehand, then you can say, here's a diagnosis, the primary polycythemia rubra or primary diseases. So this is the approach that we need to learn, and the test that you need to do exclude the other secondary causes. As I already said that the primary and secondary, what the test that we need to do, the first test we need to do is a red cell mass. It increases the primary. The second test, of course, the WBC, platelets, splenomegaly by ultrasound, but in his case, the spectrum is done, and vitamin B12 binding protein and the LAP score, all are increased in primary, not in secondary. Next test is the erythropoietin level. Is normal in case of primary, but definitely increased in secondary. And also to do the test for the heart, lungs, for the physiological causes. For the physiology, the hypoxia. So arterial blood gas will give us hypoxia in case of secondary, but normal partial pressure of oxygen in primary. If the hypoxia is present, then you need to evaluate for the heart and lungs test for the chest X-ray, CT, chest, along with the heart test for the ECG, X-ray, and echocardiography. The test should be done. And next, the pathological causes. If the secondary that you are thinking, then you need to do for the liver ultrasound along with the alpha fetoprotein to exclude the HCC, and the renal ultrasound for the RCC, and also the ADPKD to be excluded, my dear. And the polycythemia rubra vera is treated by the PRV. Yes, my dear, P for PD in aspirin, because the hyperviscosity. So we need to prescribe the patient on aspirin. And R for the hydroxyurea, R is there. It's an anti-proliferative treatment, my dear. And V for venesection. Venesection is the treatment of choice. So in his case that we have found the venesection marks. So you can say that the putting all them together, my clinical diagnosis of this gentleman is polycythemia rubra vera. Keeping in your mind, my dear, PRV. So P for, as I say, the plethora, P for pruritus. Pruritus marks and excoriation marks and the pruritus marks. And R for red complexion. This is important, means the plethora. And V for viscosity, means the venous thrombosis, means the DVT. And V for venesection marks. These are the bedside evidences, so that you can say polycythemia rubra vera along with the splenomegaly or splenectomy. So these are the evidences that you can say the polycythemia rubra vera is a treatment, and polycythemia rubra vera is a clinical diagnosis at the bedside. So what I said the P for plethora, P for pruritus, R for red complexion, the total whole bodies, and the ecchymosis, bruises altogether. PRV, V for venesection marks and V for viscosity and hyperviscosity, as evidenced by the DVT, venous thrombosis, as evidenced by he has got the conjunctival congestion, and maybe the patient may have the stroke, cerebrovascular disease. And also sometimes the people will have some of the bleeding manifestations as well. So these are all them together. The polycythemia rubra vera is a likely diagnosis of this gentleman. Very interesting case, my dear, real exams. So the summary talk, you will get the plethora, the diagnosis polycythemia rubra vera. You found the splenomegaly, polycythemia rubra vera. You found the splenectomy, polycythemia rubra vera. You found the venesection marks, you found the DVT, you found the conjunctival congestion, you found the plethoric body complexion, full body complexions, and some of the scratch marks once again. The diagnosis, polycythemia rubra vera. Sometimes the scenario is given, this gentleman has a history of extreme itching after hot bath. So this is also another important clues to reach the diagnosis of polycythemia rubra vera. So yes, my dear doctor, I hope that putting all them together, the discussions and the case will give you the extreme learning, my dear. I hope that you enjoyed. Thank you very much. Thank you once again.